Hello, and welcome to today's episode of Taking Control of Your Diabetes. I am Dr. Steve Edelman, and today we'll be talking about sleep apnea. Sleep apnea is a very common and serious condition that affects many people in our society, and especially those living with diabetes. Sleep apnea can do a lot more than make you feel extremely tired and just plain lousy during the day. In addition to reducing work and school performance and straining mental and emotional health, it can affect your heart and cardiovascular system and make your diabetes much more difficult to control. With us today to discuss this very important topic is Dr. Shazia Jamil. Dr. Jamil is a lung, critical care, and sleep medicine specialist at Scripps Clinic in San Diego. She's an expert in sleep-related health. Welcome, Shazia.
Oh, glad to be here.
What is sleep apnea, and how common is it, and especially in the general population and people with diabetes?
Okay, Steve, I think it's important to understand what is apnea in medical terms. So, medically speaking, apnea is cessation of airflow for a minimum of 10 seconds. Sleep apnea is when there are repeated episodes of apnea as well as hypopnea, which is decreased airflow throughout the night when the patient sleeps. So these patients can be absolutely normal with no problem with their airflow, no problem with their breathing during daytime. However, when they sleep, this is a problem that arises. Now, in terms of prevalence, most studies have showed us that prevalence is much higher in male compared to females. About 4% of U.S. population in terms of men have sleep apnea and 2% in female.
Well, let me ask you, does it also increase with weight? We know that our society is getting heavier, and when I think of obstructive sleep apnea, I think of like someone sitting on my chest. I know a lot of people with type 2 diabetes have that central weight problem.
Yes, absolutely. Obesity is the most common risk factor for sleep apnea, and especially what we call a central obesity or truncal obesity. So we look at neck circumference, we look at abdominal adipose tissue, and those patients are much more higher at risk for sleep apnea.
How does sleep apnea affect functioning during the day and quality of life? You know, you see so many patients with it. What do your patients tell you?
Yeah, so despite the fact that it's a sleeping disorder, but it does have medical consequences during daytime. Sleep apnea leads to fragmented sleep at night, so the patient keeps waking up. However, a patient may not know that they're waking up all night long, even if they're waking up for a few seconds or, 30 seconds or more. However, during daytime, they may have the most common symptom being excessive daytime sleepiness. So they are sleepy, especially under boring circumstances. They may be dozing off while driving, while operating a heavy instrument, or doing whatever normally they do at job. The other things can be simple morning headaches. The patient wakes up, he thought he had a great sleep overnight, but wakes up with morning headache. That could be one manifestation of sleep apnea.
Well, how does a patient really know they have it?
So these are just the two symptoms that I described to you. There are many, many symptoms. I regard sleep apnea as something which actually affects the entire body. So for example, during daytime, the patient may be irritable, there may be mood changes, outbursts of angers. Those are the things that we may see in patients who are sleep deprived. So the studies of sleep deprivation in humans have shown these symptoms, and we see the same symptoms in sleep apnea patients. Now, specifically, the important thing is, what were the patient's behavior during nighttime? What was the patient's spouse or significant other has seen patient doing at nighttime? So it's very, very important that we understand whether the patient stopped breathing during nighttime, whether the patient had heavy snoring during nighttime, or if the patient was seen to choke or gasp during nighttime.
Well, how do you make the diagnosis? What's the most standard test that people should get if they think they have sleep apnea?
The physical examination, especially, for example, looking at vital signs, seeing if the patient has hypertension, any sort of arrhythmias, looking at head and neck examination and seeing if the patient has short neck, large neck circumference, looking inside their mouth to see if they have a small opening at the back of the throat. All those things are important. Cardiovascular system examination, very important, making sure that they are not in heart failure. And overall central obesity, or looking at abdominal girth, very, very important. The American Academy of Sleep Medicine and American Thoracic Society has actually recommended that polysomnogram, which is a technician-attended lab-based, a sleep lab-based test, to be done.
So people go to the hospital and they observe them sleeping in a laboratory?
Yeah, so although I did say this is a sleep lab, but people do ask me if it's a lab, like a white lab with a lot of light. But, well, this is a sleep lab which kind of mimics a hotel or a motel room. We want to make patients very comfortable so that they can sleep, because if they don't sleep, then we won't be getting a good recording.
Like Four Seasons versus Motel 6, I see.
It's pretty nice. I must say it's pretty nice. So what happens is that the patient comes around 7:30, 8 p.m. in the night, and a technician who is very well trained in the field of sleep medicine places multiple sensors on the skin of the head and
oh, that's easy to sleep.
There's a snoring microphone. There is a small air pressure right, near the nostril to measure the airflow. There is respiratory muscle bell. There is an abdominal muscle bell. There is leg sensor.
Wow.
EKG, oxygen monitoring system called pulse oximetry, which the patient wears on a finger, as well as body positioning.
Shazia, why do they call it obstructive sleep apnea?
So I brought an anatomical model to explain why this disorder is called obstructive sleep apnea. So first of all, there's a problem with the upper airway. It could be a soft tissue abnormalities, could be skeletal abnormality, or it could be pharyngeal muscle abnormality, or a combination of all three components. If you look at this head and oral cavity section, this is called a sagittal section, the patient's pharynx is just this area which is right here. Okay, so the back of the throat or back of the base of the tongue. As you can see, even in a normal, this is a normal oropharynx.
Lots of room for the air to go through.
Exactly, and from here, the air goes through the trachea, which is a windpipe, and goes in the lungs, and from the air, the lungs extract oxygen, as simple.
Well, you brought one of these tracings from one of the polysomnograms from your sleep lab, which I imagine was taken from a patient. Can you explain that to us?
So, Steve, I did bring a recording of polysomnogram. This is a 5-minute per page. We have hundreds and thousands of pages, and this is all compressed data. So this is my patient, 30-year-old, who is obese, and we diagnosed him with severe obstructive sleep apnea based on the polysomnogram. These are the brain activities which are recorded from the scalp. Remember the electrode I talked about, the eye activity, the patient's chin activity. There is the snore channel, and I must say, look at the snoring being recorded as pretty high.
Spikes, the higher the snoring.
Yes, and the snoring is a recurrent phenomenon. That's why you're seeing it all over. This is airflow channel, thoracic effort, which is a respiratory muscle effort, abdominal effort, and saturation.
So the more effort, the more likely that person has sleep apnea?
No, not exactly. So the airflow is very important for you to look at. Just look at this example. The airflow is almost flat. So this is a normal airflow when the patient's having air going nicely through the nose. And now it's flat. And you can look at the respiratory and the thoracic effort. The patient is struggling. So there is some activity. Okay, so the brain knows that there's something going on, there's some activity, and this event is called obstructive sleep apnea. Mind you that this event has to be at least 10 seconds of duration in order for it to be called as apnea.
Well, I'm glad they have experts like you to interpret those results. Let's now go to the Spinazzola family. Mike has been unknowingly living with sleep apnea for many years until his wife, Erica, finally got fed up with his incredibly loud snoring in the bedroom and asked him to be formally evaluated.
My business, I was tired. I wasn't able to concentrate and focus as much as I wanted to. So even on weekends, sometimes I'd come home and need to take naps just to get through the evening. Years ago, when my wife started telling me that I was waking up in the middle of the night and I was stopping breathing, I kind of ignored it. I wasn't really willing to go to the doctor. Then last year, before I was diagnosed, I stopped breathing. I felt like I was drowning in the middle of the night. I'd have to take some big deep breaths. I'd get up out of bed. That kind of woke me up, made me decide to go to the doctor. Yeah, I went to the doctor and he wanted to do some tests. He gave me an oximeter for my finger, and the results came out that I had severe apnea. And at that point, I went on a CPAP and was tested about a month later, and it confirmed exactly what he told me. I travel very often, so for the most part, if I'm going more than one night, I will take my CPAP machine. Sometimes in some hotels it's tough to find a plug nearby, but you seem to manage. I could tell the difference whether I bring it on the road or not, so basically I'm trying to bring it as often as possible. The CPAP machine has made my quality of life much better with my family, especially when we travel. I'm able to play with them in the pool, run around with them in the afternoon when I don't need to go take a nap or try and take it easy. And I can help them with homework. You know, before I was very tired and not really be enthused to do homework with my children, but now it's working great, and I think we could spend more time together.
As you can see, sleep apnea is truly a family affair. Mike's story is pretty classic. If you are experiencing this pattern of snoring loudly, alternating with periods of apnea or non-breathing, and if you are always tired during the day, then you may have sleep apnea. Well, Shazia, let's talk about treatments. What are the best treatments for sleep apnea? What do they use first in these people who have it?
So the sleep apnea treatment is divided into primary treatment as well as adjunctive treatment. So let's talk about primary treatment first. Continuous positive airway pressure, abbreviated as CPAP therapy, is the standard of treatment for sleep apnea at this time. And I've brought some models here to show you what it means. A nasal mask is worn over the nose and air is blown through this mask. The primary purpose is to just keep the upper airway open throughout the night so that there's no collapse.
So these devices is hooked up to an oxygen
tank? There's a hose that hooks up to the mask, and the hose is hooked up to a small machine which actually takes room air and pressurizes it and goes through it. So a lot of my patients ask me when I'm discussing PSG results, polysomnogram results with them, as to how are we going to get oxygen. We have several low oxygen saturations. Do we need oxygen? Well, no, you do not need oxygen. There is no problem with your lungs. The problem is the entry of air into the lungs. So what we're trying to do is to just get this upper airway obstruction relieved. This is a nasal CPAP mask. This one is nasal pillows. There are multiple different kinds of CPAPs, and it's not like one type fits all. You just have to look at patients' facial structures as to, which one would fit them better.
Well, I have to say, my friend Mike Spinazzola, who we just saw, he is the type of guy who I didn't think was going to wear the mask, but he feels so much better during the day. He takes it with him everywhere. Now, I see you brought, I didn't know you were a dentist. You brought some teeth here.
Yeah, I'm going to talk about the second line of treatment, which is called mandibular repositioning devices. These are the devices abbreviated as MRD, if you see them written in medical literature. And basically what they do is the dentists custom made these devices, which patients wear on the upper and the lower jaw, and they move the jaw forward. The difference is only a few millimeters difference in the caliber of the upper airway. However, it does make a difference in terms of apnea and hypopnea. Now, as I said, this is the second line of treatment. So this is for patients who absolutely cannot tolerate CPAP for one reason or the other, and patients who have mild to moderate obstructive sleep apnea. These devices are not at this time recommended by American Academy of Sleep Medicine for patients who have severe sleep apnea.
Are there any other therapies?
Well, weight loss is an integral part of treatment of sleep apnea. All my patients, if they are overweight or obese, have to have some kind of a weight loss program with diet and exercise. And it's well known to cause decrease in sleep apnea severity. In some cases, there have been patients who have completely relieved of obstructive sleep apnea because of reaching an ideal body weight. Now, weight loss can also be achieved in morbidly obese people with bariatric surgery. The other thing is there are patients who, despite adequate treatment with CPAP, continues to have excessive daytime sleepiness. And this is, of course, a major functional disability, and they're working and they have to drive, etc. And modafinil is a medication that has been approved for that reason. However, we absolutely have to make sure there is no other reason other than sleep apnea that the patient is having sleepiness. And the patient is being adequately treated with CPAP. So it's an adjunctive therapy.
I see.
And finally, there are patients who have severe rhinitis, nasal congestion, and they absolutely either cannot wear CPAP or their sleep apnea is getting worse because of their nasal symptoms. In those patients, topical corticosteroid sprays have been shown to improve.
Okay.
And again, I would like to emphasize that the patients who use alcohol at night, sedatives, hypnotics, narcotics, all these medications can exacerbate sleep apnea. So it's very important if you're diagnosed with sleep apnea, even if you've started treatment, that you avoid these drugs and medications.
Well, as we've just heard, sleep apnea very often strikes people who are overweight and especially those with type 2 diabetes. However, sleep apnea can also strike the thin and the young, and it also runs in families. Let's talk to Chris Sadler about how sleep apnea has affected him and his family.
I always suspected that maybe there was a problem. I used to snore very heavily even as a child. I was a competitive runner through high school and then through college, and I always felt like I was always more tired than everyone else. I needed a nap every afternoon, and then as I got to be a working adult, I found that in the afternoons I was falling asleep at my desk around 2 or 3 in the afternoon, just nodding off, and finding I just didn't have the energy that I thought that I should have. Never thought about it that much until my wife finally noticed that I was stopping breathing during the night, and she was having to nudge me during the night. And then I actually went and had a sleep study and found out that I did in fact have sleep apnea. So part of the process of being diagnosed with sleep apnea is to undergo a sleep study. This is not the most fun procedure. You go to a sleep lab and you're expected to sleep with electrodes attached to your head, to your chest, straps, something over your airway so that it monitors your breathing, things on your finger to monitor your pulse oxygen levels. So it's really very uncomfortable to sleep with all this stuff, but it's a very effective way to diagnose the illness. So I did find out through the process that my sleep apnea was related to my anatomy, that I have a very narrow airway just anatomically, just the way the lower jaw developed. It didn't develop fully, and so my whole base of my tongue and my jaw sits back farther, and so the airway is just razor thin in the back. So after I was diagnosed with sleep apnea, I realized that my daughter might have the same problem, and the reason was she was always tired. And I thought, well, you know, if I have this anatomy, she may have inherited the same anatomy with a very narrow airway. So we had her tested and find out that she did indeed have sleep apnea. And she's a beautiful 19-year-old girl, and to commit her to CPAP for the rest of her life would just not a decision that I could live with. Also, she had a very narrow nasal airway that wouldn't tolerate CPAP. So we opted to have her go through surgery to actually move both of her jaws forward to allow her airway to really open up. And the surgery was very successful, and it enlarged her airway about 3 times bigger than its original size. And now she's breathing very well and sleeping well. My wife is much happier because I snored very loud previously, and so I don't make so much noise. It took her a little while to adapt to the noise of the machine. It's very quiet, but there still is a little bit of background noise, and so it took a little while to adapt to that, but I think we were both sleeping much better than we used to. My life after using CPAP has improved significantly. It took me a long time to adapt to the therapy, but after adapting to the therapy, I find that I have much more energy during the day. I don't nod off in the afternoons any longer. And so now it's really added to our quality of life so that I come home with some energy at the end of the day to still do some things together as a family. I do quite a bit of traveling and speaking, and it is a little bit of a hassle to carry the machine with me, but the machines are getting smaller and getting easier to travel with. The airport security always wants to check the machine, so that's kind of a hassle, but the therapy, I wouldn't go to sleep without it now.
Wow. It's amazing how sleep apnea runs so strongly in families, and that it can affect anyone, no matter what their age or their weight. Shazia, surgery seems like a pretty drastic step. What are the pros and cons of surgery, and how often do you need to go to this step?
Well, there are different types of surgeries which are employed in the treatment of obstructive sleep apnea. The most important thing is that the sleep medicine physician and the ENT physician have to really evaluate which patients are going to benefit from surgical procedure, and then there is a judicious selection among a variety of surgical procedure as to which one has to be employed in a particular patient. So it's not that one surgery fits all. So for example, in children and adolescents, a lot of patients of that age group has tonsillar hypertrophy or adenoid hypertrophy. So a simple classical procedure would be removal of the tonsils as well as the adenoids. Now there are other procedures which are called UPPP, uvulopalatopharyngoplasty, in which part of the soft palate is removed, uvula is removed. If there are tonsils, they may be removed, tonsillar pillars, or
They remove tissues that
there's a lot of
lead to
tissue, upper
obstruction.
airway, exactly, in pharyngoplasty. So they're trying to modify the upper airway size. So you really have to see which patients are going to benefit. Now, if patients definitely has a structural or anatomical reason to have sleep apnea, yes, surgery would be a way to go. In terms of further specialized surgery, we have special ENT surgeons which are interested in obstructive sleep apnea, and they do very specialized procedures. For example, maxillomandibular advancement, also known as MMA, in which they cut the bones of the jaw, the upper jaw, which is called maxilla, the lower jaw is called mandible, and it's kind of pulled forward and is wired over a few weeks or so. And then basically you may need additional stage procedure to realign the teeth and increase the upper airway increase in size. So there are some of my patients have undergone that extensive surgery too.
Well, I would imagine when I spoke to Chris Sadler, he said his daughter, she's so young and she has it, it's worth going through the surgery because she's got the rest of her life to live. Now, we heard from Mike, who is at very high risk for type 2 diabetes. It runs in his family. He has elevated blood sugars. How does obstructive sleep apnea affect the diabetes?
That's a very interesting question. There are studies in the literature that shows that patients with obstructive sleep apnea have diabetes, and that may be because of the common risk factors. For example, patients who have both type 2 diabetes and obstructive sleep apnea may be middle-aged, may be male, may have obesity. So it's very difficult to disentangle the exact relationship. However, studies have shown that obstructive sleep apnea can make glucose control worse, especially maybe nocturnal glucose control, and that CPAP actually helps that. There are studies which have shown that obstructive sleep apnea actually causes insulin resistance, and CPAP normalizes insulin resistance. And as you know, being an endocrinologist, that's a major problem in type 2 diabetes. Now, there are preliminary results from our Scripps Clinic Sleep Center group, and we actually presented it in the American Thoracic Society 2007 meeting, where we had shown that patients with sleep apnea and who also had type 2 diabetes, their nocturnal blood glucose decreased with the CPAP treatment, and it kind of became more stabilized rather than having surges of glucose. So this is preliminary result, and at least it has been presented, and it's ongoing study.
And we know that if you have type 2 diabetes, you have a tendency to gain weight, and of course the weight can make that obstruction worse as well.
Yes.
Now, we know that heart disease is a big issue in people with diabetes, especially type 2. And there's so much in the literature now about sleep apnea maybe exacerbating cardiovascular risk factors and causing heart disease.
Just like I described the relationship between obstructive sleep apnea and diabetes and the presence of common risk factors, the same holds true with cardiovascular disease. Obstructive sleep apnea, diabetes, and cardiovascular disease may be present in the same population group. For example, male, sex, aging population, patients with metabolic syndrome, patients who are obese. So again, it's very difficult to see exactly what caused what. However, there's mounting evidence that shows that there is relationship between obstructive sleep apnea and cardiovascular disease. For example, the Wisconsin cohort study was the first one to point out that sleep apnea may be a risk factor for hypertension, and this was further confirmed by many other studies. There is Sleep Heart Health study, which was a large population-based study which also shows that sleep apnea and hypertension is related. There are studies on heart failure and obstructive sleep apnea, and as you know, heart failure can be divided into pump dysfunction, which is systolic dysfunction, or diastolic dysfunction, which is inability of myocardial muscles to relax. Now, sleep apnea is possibly present between 5 to 10% of patients with systolic dysfunction and 50% of patients with diastolic dysfunction. So, since we talked about what sleep apnea does, it's important to understand that there are recurrent oxygen desaturations, there is recurrent sympathetic activity, which is because of arousals, and intrathoracic pressures may be increased and may be affecting the heart.
I mean, the bottom line to me, not being a pulmonary doc, is that, getting oxygen to every tissue in our body is important. And, when you have anoxia or not enough oxygen, a lot of things can happen. And the sleep apnea situation seems to fit in, maybe not distinctly, but sort of blend in with all the other factors that we call the metabolic syndrome: type 2 diabetes, central obesity, high blood pressure, high incidence of heart disease. So I think, your answers have told us that it's a pretty important disease to treat. Now, since a lot of people may be affected by this, where can they get more information?
I think the best source to go would be American Academy of Sleep Medicine website. And now this is a large society which is dedicated exclusively to the specialty of sleep medicine, and they are very well involved in healthcare, public policy, education, and research. And the patients can go to www.aasm.net. There is, on the left-hand side, there is a corner where they can click. It's a public and the patient. So it takes it to another website, which is sleepeducation.com. And try to understand their disease. I cannot overemphasize the importance of education, especially in a disease which is a major public health issue.
Shazia, thank you so much for sharing your expertise with us on today's show.
Thank you.
Well, we're coming to the end of today's show. If you have any questions or comments, please email me at askdre@tcoid.org. So remember, you have the main responsibility for taking control of your diabetes. You are your own best advocate. Be smart and be persistent. So goodbye, until next time. Take control of your diabetes. You owe it to yourself and your family. Sleep apnea is a serious condition that can dramatically affect your health and family life. When a patient comes into the office and complains of being tired, I admit, I sometimes don't take them seriously. Who isn't tired all day? Being tired is the most common symptom in all of medicine. After watching this show, if you think you have sleep apnea, don't just go in and complain of being tired. Tell your doctor that you think you might have sleep apnea. Remember, you need to help your doctor take better care of you.